Hello, this is Professor Wheeler. This is our lecture on substance use disorder. Our reading is Erstmeyer, Chapter 14, Substance Use Disorders. The associated VSIM is Andrew Davis. That's his photo on the front of this PowerPoint. Our objectives, the first objective defines substance use disorder. We're going to go into the 11 criteria that the DSM-5-TR designate as criteria for substance use disorder, and how many are required to designate it as mild, moderate, and severe. Number 2, demonstrate increased self-awareness of personal values, beliefs, and feelings about substance abuse. And this is critically important because people with addiction issues are very sensitive to any kind of judgmental attitudes that you as a nurse might have. Some of them will say that that's the reason why they didn't come to treatment sooner was they have their own shame around their addiction, and then if they're worried about the nurses being judgmental, and even worse, the nurses not giving them enough medication to comfortably detox, then they don't come for treatment. So your attitude is critically important when it comes to successfully helping patients detox and get into recovery. Number 3, compare and contrast the major categories of abused substances. The critically important thing in this objective, number 3, is just learning the different detox protocols. There's some medications that are deadly with detox, mainly alcohol, benzodiazepines, and barbiturates. The ones that are depressants, those are the ones that a patient can die. And then there's other ones where it's just very uncomfortable with, I'm talking about opioids and stimulants. Number 4, we'll discuss fetal alcohol syndrome, which is it's birth defects related to the mother drinking a lot of alcohol. How to help the mother not feel so ashamed so they can be there for their child. Number 5, identify behaviors, genetic and environmental factors that contribute to substance abuse and develop a plan to reduce risk factors. Number 6, work with the patient to develop a plan that ensures safety, comfort, protection, restorative measures, coping skills, and prevention of further substance abuse. Number 7, learn how to make appropriate community referrals for patients with substance use disorder. Number 8, gain an understanding of chemical dependency in the profession of nursing. The Nurse Practice Act as it applies to impaired nurses and the Board of Registered Nursing Interventions. So if you do in your nursing career get a substance abuse issue, it doesn't necessarily mean you lose your license. You can be on diversion, and there's different programs for that. Number 9, review the signs and symptoms of codependency and discuss their relationship to substance abuse. Objective 1, define substance use disorder. These are the DSM-5-TR substance use criteria, the 11 diagnostic criteria. So these, depending on how many of these criteria the patient meets, that's where you'll say they're mild, moderate, or severe. So number 1, taking the substance in larger amounts or for longer than you've meant to. And this is the classic where you go out to a bar, you say to yourself you're only gonna drink 2 beers, and you end up drinking 6 beers, 7 beers, and having a blackout. Number 2, wanting to cut down or stop using the substance but not managing to. So in other words, you want to quit but you can't. Number 3, spending a lot of time getting, using, or recovering from the substance. The first part, a lot of time getting, that mainly refers to illicit, kind of illegal substances that you have to find somebody out there getting them, and then recovering from the substance. We're talking about hangovers and things like that. Number 4, cravings and urges to use the substance. Number 5, not managing what you should at work, home, or school because of the substance use. 6, continuing to use even when it causes problems in relationships. So an example of that, there's people that their spouse has told them they're going to leave them if they don't stop drinking, and they're going to lose their job, and they still continue to use. Number 7, giving up important social, occupational, or recreational activities because of substance use. Number 8, using substance again and again, even when it puts you in danger. And so, some of the things that we've seen in recent years, people addicted to the opiate fentanyl, they'll continue to use even though it's really unpredictable what you're getting when you get illicit, illegally made fentanyl. And so there's a lot of overdoses. Number 9, continuing to use even when you know you have a physical or psychological problem that could have been caused or made worse by the substance. We see this a lot with patients who have bipolar disorder or schizoaffective disorder or a psychotic disorder, and they use substances that can actually cause the same symptoms. The biggest example is methamphetamine, where the use of it actually mimics the symptoms of their illness, and so can make it worse. Number 10, needing more of the substance to get the effect you want. And so in other words, to get the feeling that you're looking for, you need to use more and more of the substance because you're developing tolerance. Number 11, development of withdrawal symptoms, which can be relieved by taking more of the substance. So a good example of this, people that are real serious alcoholics, when they wake up in the morning, they'll need what they call an eye opener. In other words, they'll need to have a drink in the morning just to kind of stave off the detox symptoms. The DSM-5 has it where it can be specified mild, moderate, or severe. So 2 or 3 of those symptoms on the previous slides, that's mild. 4 or 5 is moderate. 6 or more is severe. It can be grouped into 4 categories: physical dependence, which is tolerance and withdrawal; the risky use we talked about; social problems; and impaired control. Impaired control is the start of where it starts getting bad. All right, so this is just kind of fleshing out what we were just talking about. Classes of psychoactive substances, probably no surprises in there. Some people include caffeine and things like that. I feel like that makes it where we don't take the serious ones as serious when we start putting things like that in there. Caffeine and nicotine are sometimes added to these categories. Risk factors, genetic and environmental. So family history, we know there's a genetic component. Having prior psychiatric issues, sometimes the illicit drug use actually does help in the very short run, usually a disaster in the longer run. Having a history of abuse, or what we like to call ACEs, which are adverse childhood events, and loss and grief. Some of our theories, biological, that the different drugs, they release neurotransmitters, and those neurotransmitters make us really feel good. One of the problems with that, the reason why it causes addiction, is because the drugs don't give you more of your neurotransmitters that make you feel good. They just make your system push them all out at once. And so what happens is our normal chemicals that make us feel good, they usually come to us very slowly. And so when you use these things that make them come out all at once, you deplete your natural resources, and you don't feel good when you're not using your substance. Then we have psychological factors, and so just kind of a natural lack of tolerance to what the substance is, feeling like you're not a success, not having good relationships, and having lower self-esteem, and a tendency to want to take risks. You need to have danger to feel alive for some people. Changes can include being in denial, being depressed, anxious, hopeless, and other kind of psychiatric problems like, major depression is common. Sociocultural factors, social learning, children and adolescents, we we would like it if they would just do what we tell them to do, but they don't. They do, they learn by watching us learn what we do. And so if we are drinking alcohol or using other drugs to change our moods, to feel better when we have a stressful time, that's what they're going to watch. And so if you've seen your parents do that, that's that's what you're going to do if you kind of lead a life that's not examined. They can be promoted within your peer group. When I was in the 7th grade, when I was 12 years old, my mom asked me to promise her I would never use drugs, and I did. And so when I was with a group of my friends and somebody took out a marijuana joint and they were passing it around, I said, I said no, because I promised my mom I wouldn't. And I was made fun of for that. And so the next time it was being passed around, I did use it. And so that's peer pressure, kind of classic peer pressure. So conditioning, just thinking of it from a behavior therapy point of view, it does reinforce its own use. And then some cultures are more prone than other cultures, and some of it, I'll give you an example. Some of the things from my heritage, in the Irish culture, you're supposed to drink to kind of show your manhood, to show you can hold your liquor, and that's like how a lot of the men bond, and you're not really considered a real man if you can't drink. And so that's a culture that's very prone to substance abuse. All right, objective 2, demonstrate increased self-awareness. So generally in a live lecture, I would have you generate your self-awareness by having you talk in groups amongst yourself, and you can still do that when you're in your study groups. Just And sometimes our feelings about the substance can be, if you had a parent that was an alcoholic, you might have very strong feelings in one way or another. I know a nurse that I worked with once, a patient came in that was smelling strongly of alcohol, and she said he smells like danger. When she smelled a man that smelled that way in her childhood, because her father was an alcoholic, it meant that she was not safe for a while, and neither was other people in the house. So getting over those kind of feelings, not taking it out on our patients. That's why we need to be self-aware. Objective 3, compare and contrast the major categories of abused substances. So in this is probably the longest objective in this PowerPoint, and it's because it's the most important part of our job as nurses when we get a patient that's in detox is to be able to detox them safely. So alcohol use disorder, this is a little redundant because it's all the same as, basically it's the same as substance use disorder, except that intoxication and withdrawal is different. The substance use disorder designation is kind of an overarching, but it does have little subcategories in there with alcohol use and cannabis use and opiate use disorders. You can see that in the H&P sometimes. Right, so effects of alcohol on the body. Most of these have to do with organs, your liver especially, but also your kidneys and your whole GI system. Some of these disorders you'll recognize from your GI lecture. Cirrhosis is considered the end stage of alcoholic liver disease. It's the most common cause of death in a chronic alcoholic. And what happens is the liver cells are being destroyed and replaced by scar tissue. One of the things when you're doing an abdominal assessment on a patient who's an alcoholic, you might be surprised that their liver is actually large, but it's because the scar tissue, it's actually the liver is actually kind of it's dying basically. The cells are being replaced by scar tissue. So these other things from your GI at the bottom here, you'll see sometimes the Wernicke encephalopathy. I can't pronounce that word. And Korsakoff, they'll kind of merge those together. Some doctors see the Wernicke encephalopathy and as the acute part, and then the Korsakoff is the chronic part of like the same syndrome that are both caused by the thiamine deficiency that happens when you drink a large amount of alcohol chronically. All right, so one thing useful is there's a very easy way in your alcoholic or a patient. It doesn't have to be an alcoholic. It can be a patient whose liver is impaired in other ways, but I'm just using it in the context of an alcoholic here, where a patient can suddenly become really silly and giggly, and you might think that somebody snuck them in some kind of illicit drug, and they're high. But what happens is the liver, when the liver is impaired, it can do a poor job of clearing ammonia out of the system. And what's actually happening with the patient is their brain is reacting to the ammonia. And this is a situation where the patient can die. So it's very serious. So there's something that's a byproduct of this called asterix. I'm not sure if I'm pronouncing that correctly, but what we can do is test a patient for that. And in your alcoholic, if they have the asterixis, it's almost always a high ammonia level. And so what you do is you have the patient, it's best if they're standing, but they can just sit up in the bed and instruct them to put their arms out straight and then bend their hands toward the ceiling and try to keep that position where their hands are still. What will happen if their ammonia is high, their hands will flap. And so that's just a quick way to tell real fast what's going on with your patient if it's a high ammonia level. If it is, if their hands do flap, you need to call the doctor and get an order for a stat ammonia level. This is it's not the only condition that can cause asterixis, but in our alcoholics, that's what it usually is. In our non-alcoholics, it can also be caused by kidney problems as well. What happens, what's going on there is let me go on to the next slide. What's going on there is it interferes with the dorsiflexion, the ability to hold a contraction in your wrist. And sometimes they'll also, when you're doing your assessment of a patient, your head to toe, and you're gripping, having them grip your hands, and you're saying if they're equal or not. What you'll see, another reason why we do that is to see if they're having this kind of issue where it would make it where they can't maintain the grip. It would be kind of flapping when they try to squeeze your fingers. All right, our substance abuse comparison. So alcohol, peak period is 1 to 3 days, duration is 5 to 7 days. And you'll see that a lot of them have these same peak periods and durations. For alcohol, what's important is the highest risk for seizure is 24 hours after the last drink. So it's critical to find out when they had their last drink. You can't just look and see when they were admitted, because sometimes, they hadn't drank for a few hours before they came in. And then depending on where you are, if you're on a psychiatric unit, they may have sat in the ER for, 6 or 7 hours. And so that could be totally, totally misleading if you just look at the time of admission on your unit. So our signs and symptoms: elevated blood pressure, pulse, and temperature, hyperarousal, which looks like a easy startle response. They'll sleep, but they'll be restless. They'll wake up sweaty. Sometimes you have to change their sheets. They're disoriented, and they don't have good balance. They have ataxia. So they can also, in the symptoms you see here with the visual and auditory hallucinations, that's usually a sign they're going into delirium tremors. And you probably want to try to, if you're not in a ER or ICU, you might want to try to transfer them there. When they get to the delirium tremors, we need to try to start an IV and try to give them their meds. Usually it's Ativan IV, because you can't really get it in on a person once they become delirium. It's hard to get them to swallow medications once they get delirious. All right, so this is an example of alcohol withdrawal protocol. Now, for my students, I don't want you to memorize these dosages. That's not going to be something I test you on. I'm just showing you this as an example of what withdrawal protocols look like. So when we have alcoholics on withdrawal, we have a scale called the CIWA-Ar, and the doctors will order. There'll be a certain amount of medication you give for mild withdrawal for a score of 8 to 13. There'll be a little more for 14 to 19, and then over 19, they're in severe withdrawal. And we usually are going to try to see if we can get some oral medications in them, but you should prepare to, if you're not in the ER or in an ICU, to maybe send them there. Any score over 21, and they're going to have delirium. And when I say these scores, you have to learn, and you usually learn by seeing other people do it. That's how a lot of our learning happens in all professions. But when I say a score over 21, I'm assuming it's somebody that knows how to do this correctly. All right, so here's our symptoms. So the scores range. We judge them on nausea and vomiting. So 0 to 7, 0 to 7 on tremor, 0 to 7 on sweating, 0 to 7 anxiety, and all the way down with all of those. One of the reasons to use a scale like this is because when in the days before using a scale where they would just go by the blood pressure and pulse, they found out that sometimes people, there's a lot of individual differences between people, and they could be in severe detox, but their pulse and blood pressure aren't as elevated as you would expect. So then they would still have a seizure. And so we want to look at the whole picture, not just the vital signs. If you do give medications for a patient that's on the CIWA, you repeat the CIWA within an hour, just like you would for any other PRN medications, where you have to reevaluate the patient within an hour when you give them a PRN to make sure it was effective. It's especially important with alcohol detox. Just because you gave them a little medication doesn't mean you can ignore them. You have to keep checking on them, and you do the CIWA. Like I said, you can, if it's a patient in late detox and we're not worried, you can wait 4 hours. But if if you've given a medication, you need to do it usually, like 50 minutes, like toward the end of an hour, to make sure it was effective. So treatment modalities, so just some of our meds for alcoholism. We have antabuse that we can give people that we want to be sure that they're not going to try to drink on it. And so this has to be somebody that's committed. They just need something to help them not make an impulsive drink. We have naltrexone, Rivia, and Camprol. Those are medications that help people with cravings, and then benzodiazepines for detox, and anticonvulsants. We give these same anticonvulsants, anti-seizure meds, Depakote, Tegretol, and Neurontin. You probably recognize them from your bipolar disorder lecture. Those are the same ones we give for mania. And one of the things to remember with somebody in alcohol withdrawal, our first big goal is that they don't have a seizure. Now, there was a time when we would just routinely give an anti-seizure medication with all of our people detoxing from alcohol, but it turned out we were giving a lot of it unnecessarily. But if you have a patient that has had a seizure in the past for any reason, especially if they had a seizure in the past during withdrawal, we want to make sure we get an order for one of the anticonvulsants here. Usually, seems like we usually give Depakote, but really any of those would be fine. One of the reasons we like to give Depakote on a psych unit is, sometimes we do find out that the patient has bipolar disorder, and it's just a way of getting that level started up, because you have to have a certain level in your blood before it works for bipolar disorder. And we have our vitamins that the body gets depleted of, thiamine and folic acid. Those will be in your detox protocol as well. All right, so benzodiazepines. So our short-acting benzodiazepines, which are usually the ones that people get addicted to. We're talking about Ativan, Xanax, and then the long-acting ones are Klonopin, clonazepam. So generally 2 to 4 days for the short-acting ones, 4 to 7 days for the long-acting ones, and the signs and symptoms of benzo detox are so similar to alcohol detox that at the hospital I work in, we use a CIWA scale for benzodiazepine detox. So a lot of the same things: agitation, muscular weakness, sweating, and delirium if they haven't been medicated enough, and the risk for seizures as well. The alcohol is really predictable that the real danger period is 24 hours. With benzos, it can be a little faster if it's Xanax. They don't have solid research out on the exact amount of hours, but Xanax is the worst one. And then probably Klonopin is the one that's not as bad because it's so long acting. All right. So another strategy used sometimes with benzodiazepines is called a taper. And so these are the examples of orders for a taper on a short-acting benzo. I'm sorry, on a quick kind of taper, something like Valium could be given, and usually it's going to be a benzo that's not the one that the patient uses. So we want to give them something that is going to be effective, but we also don't want it to kind of further their addiction. So example, the one people get addicted to the most because it has so much euphoria is Xanax. And so the taper would probably be something more like Klonopin because it's long acting. It keeps them covered as far as their detox. And one thing to know about a taper also is it's going to be ordered routinely, so the patient doesn't have to ask for it. So there's not those kind of power struggles between you and the patient. And we want them to get it so that they don't have problems with the detox, they don't have a seizure. All right, so we can use for depressants, phenobarb. We can use that for substance withdrawal also. Some doctors like to use that for detox from alcohol and detox from benzos. It has more seizure protection, but it's a little more sedating. So I believe the reason why doctors don't use it more is it can increase the fall risk. And then we have our long-acting benzodiazepines. Like I probably said in the psychopharmacology lecture, we don't use those very much for alcohol withdrawal because we want something that's going to work fast and wear off fast so that we can be aggressive with it. But we do use it for, for a taper. It's very good for a taper. All right, our central nervous system depressants, which are the ones we were just talking about, alcohol, barbiturates, and benzos. The effect of overdose is cardiovascular or respiratory depression or arrest. Those are the ones that kill you. So when people overdose on their sleeping pills that are barbiturates, that's very deadly. Yeah. So cause of death is respiratory or cardiovascular arrest. So stimulant use disorder. So stimulant intoxication, they can be very violent. They can be impulsive when they're very high on these substances. They can make, you know, so basically we want to contain them when they're intoxicated. Then with withdrawal, we want to treat them just like you would with a manic patient that's been manic for several several days. We want to let them sleep. They're probably haven't slept much, and so they're exhausted on the inside. And also let them eat. We're not going to limit their food. They can eat as many trays as they want. If we run out of food, we'll look for some on another unit or call the kitchen. Unless they're a diabetic or for some other reason, it's counterindicated that they be allowed to eat. Generally, they're malnourished because they haven't been eating much. Okay, our stimulants. The peak period is also 1 to 3 days in duration, 5 to 7. And what will happen with them is they'll be withdrawn. Um, they'll be very sleepy. They'll be very hungry. That's what hyperphagia means, very hungry. And one of the things that you'll see in a patient detoxing from stimulants, they'll have these very realistic feeling dreams that that feel so real. They'll wake up and you might even see them looking around on the unit thinking that their drug dealer is on the unit somewhere. That's just how bad their body is craving. They call those user dreams, and they feel so real. Um, Something to be aware of. So they can have suicidal thoughts, and they can have some paranoid delusions. Generally, those are okay. The suicidal thoughts you definitely want to assess, and generally we try to give them something like a little bit of Ativan to help with the irritability, help try to get them back to their crash, their sleep that they need. We call that a crash when they're just so dead tired when when the intoxication wears off, they're exhausted. So we call it supportive therapy, and what we mean is the Ativan or whatever it is, it kind of helps them get over the hump to relax and not be so irritable. Yeah, and we generally a low dose, just for a couple of days. So some of the things that we use, we're talking about minor tranquilizers here. We're talking about the Ativan, Valium, those kind of things. Major tranquilizers, we're talking about when they're violent, when they're intoxicated, and they can be violent. We can use, our strong antipsychotics that we use for severe agitation, like Haldol. If they're doing something really dangerous, we can give them emergency meds. It's like a shot called Haldol, Ativan, Cogentin. Well, it's not a shot, but it's usually 2 shots. Um, and then, that's we're not giving it to them for psychosis. We're giving it to them for the agitation. Then we have anticonvulsants. There's one of those seizure meds, especially called Neurontin. For some people, it does help them stay calm, and so that can help them as well, stay calm, but with a medication that's not addictive. So next we have opiates. You're probably aware there's a crisis in this country with fentanyl overdoses. This fentanyl was a medication we used for a long time that was very useful for pain, but it's you know drug dealers and drug makers, illegal drug makers, have learned how to make it on their own, and so now you don't know what you're getting. So the doses can be way too high, and that's why we have so many overdoses. So again, 1 to 3 days is the peak period, 5 to 7 duration. The big thing to remember with opiates is the person doesn't usually die from the detox, but it's miserable. They have a lot of nausea, vomiting, and diarrhea. In the past, when I've seen a patient that wasn't medicated well enough, that patient just stayed in the bathroom and laid on the floor so that when they had to vomit, they were right there to vomit in the toilet, and then when their diarrhea came on, they were right there also. They didn't want to soil themselves trying to get to the bathroom in time. So this is a miserable detox if they're not giving medication enough. I've had long-term heroin addicts tell me that the detox is so nasty that they would do anything to avoid it, and including not stop their drug use. And so that's why they really have to trust you when they come in. They have to trust that you're, number one, like I said earlier, that you're not going to be really judgmental, and number two, that they're going to get the medication they need to not be as miserable in with this detox. And so we have the symptoms here: dilated pupils. Um, if your piloerections last longer than 4 hours, it's okay. It's only goosebumps. Sorry, that's my piloerection joke. We have they'll have a runny nose. Their eyes will be watering, um, and they have mild hypertension and tachycardia. Don't confuse that with the very serious, severe, mild. I mean, sorry. Let me start that sentence over. Severe hypertension and tachycardia they get with alcohol withdrawal. It's mild with opiate withdrawal. So they'll have muscle cramps, joint pain, and just really feel terrible. It's like the worst flu you've ever had in your life. So, so detox protocols for opiates. There's a classic strategy with clonidine where it's you're giving them a medication that keeps their blood pressure down throughout the day. It has other things about it that's a little more complicated that helps with opiate withdrawal. You do have to take their blood pressure before each dose, just like you would anytime you're giving a cardiac medication, to make sure their blood pressure isn't too low. Usually the clonidine, well, both of these, there'll be something like Bentyl for stomach cramps. There'll be a lot of different little things that are added, but those are the main things. Then we have buprenorphine. This is the most comfortable detox because it covers the opiate receptors. And I've seen it where a patient was critically, very sick, and then when I got him on the buprenorphine, when I got that ordered and I gave it to him, half an hour later, he's going to group. He's saying inappropriate comments to females, and he's back to his old self. So let's see. There's something called the cow scale that we're going to talk about on the next slide that'll determine how much medication they get. So let's see some of our treatment modalities. So for opiates, we have the antagonist, which the one that kicks it out of your system for opiate overdose, Narcan, generic name naloxone. Then we have for cravings, Rivia, it's naltrexone. Naltrexone is also given for cravings for alcohol. Methadone has been used more and more. I keep hearing. We don't do that at Herrick, but they do use it for detox in other hospitals, is my understanding. And then buprenorphine, Buprenex, like I said on the previous slide, and then Clonidine, like I said on the previous slide. And then we have Suboxone, which is a combination of Buprenex and naloxone, and that's to help people stay clean from opiates. One of the things it does is the Buprenex keeps those cell receptors that are screaming out for the opiates, keeps that under control. And then the naloxone part, if they did use an opiate on Suboxone, they would get really sick. It has just enough of the Narcan in it to make them sick. The naloxone, just a little bit to make them sick. All right, so this is our clinical opiate withdrawal scale. So the cows is different from the CIWA in that you only get it, you do that assessment on admission, and the doctor makes the orders based on the numbers that you give, the score you can see at the bottom there. And if it turns out that the patient seems like they're not getting enough medication, or if they're getting too much medication and they're over sedated, you can redo the scale and call the doctor and get more orders and get it updated. But you don't have to do it. You don't do it several times a day like you do with the CIWA. So we are things like PCP. This is a dangerous one where the patient can become very violent. The giveaway that they're on PCP is these repetitive, uncontrolled eye movements. They go either from side to side or up and down. But that if you ever see it, you'll know that patient is on PCP. And the reason why that's really important to know is they can be very violent. They can also be very self-destructive. They feel like they have superhuman strength. They sometimes they will jump off a building thinking they can fly. Um, very, very dangerous medication or substance for your patient to be on. And we have cannabis-related disorders. So intoxication, they're disinhibited, they're silly, they're giggling, and then withdrawal, they're anxious. And we usually treat their withdrawal just simply with some Ativan, just a benzo for a couple of days to help them get over that. Hallucinogens, people generally don't get addicted to these, but they are very troublesome. So we have LSD, we have the psilocybin mushrooms, PCP. These last two, ketamine and MDMA, they're hallucinogens. We there's a little subcategory. We call those more dissociative type of drugs. Um, these can make their emotions be wild. It can make reality feel bizarre. They can make the user feel out of control, disconnected. And the way they feel disconnected from their body and environment, it's like a disorder that you'll learn about later on in the semester in the dissociative disorders lecture called depersonalization derealization disorder. So it's like taking these kind of drugs, it's like giving yourself that disorder. All right, so for hallucinogens and for marijuana, benzodiazepines for the withdrawal, and then if they're violent, if it's somebody that's on PCP or somebody that is having what they call a bad trip on their LSD, you can also use antipsychotics that just for their severe agitation effect, usually in an emergency medication order, like a haldol-ativan cogentin, or we use Zyprexa for that kind of thing as well, Geodon, those type of medications. So like I said here, the patient on PCP can be very violent. Objective 4, discuss fetal alcohol syndrome. So this is a typical facial features of the person with fetal alcohol syndrome. The big thing that you want to do as a nurse if you have a mother that has a child like this is, do whatever you can to help her not feel the shame. And again, you know how the NCLEX loves for you to examine your feelings and beliefs. You know, sometimes it's natural if you see a child that has a birth defect because the mother couldn't stop drinking or was an alcoholic. Um, you can be you can find yourself having anger at the mother for that. Um, so you need to get over that. That doesn't help your patient. What your patient needs from you is acceptance, first of all, and you need to help them see it differently. That yes, I had an alcohol problem. A lot of times people don't know they're pregnant early in the pregnancy, and they're drinking a lot, you know, and so, and even if she did know she was pregnant and couldn't stop drinking, still what you want that mom to feel is that, okay, I made these mistakes, but I'm gonna get clean and sober now because my child is gonna need me. This child is gonna have problems, and they're gonna need me to be clean and sober and ready. And you, they need to rebuild their feelings about themselves in looking at it like I'm going to be a great mother from now on because I have this child that's going to have special needs and really needs me. I'm not going to fail them again. I'm going to I'm going to make sure their life is good. So these are characteristics that were in the previous slide in the photo. Objective 5, identify behaviors, genetic and environmental factors that contribute to substance abuse and develop a plan to reduce risk factors. So polysubstance abuse, so a lot of our serious drug users use several substances. They might just use what is available. Sometimes they don't have the money to use their preferred substance, and so they just use whatever's around. Um, and sometimes it can be, they go with people that have the drug and go to their parties and do things, and that's that's what they kind of use what they get. So they can come in and they can have a cross tolerance. They might be addicted to more than one thing, and what can be dangerous is if they're addicted to like two separate downer type of drugs. Um, your normal dose of your benzos for, an example for a patient that's on CIWA orders for alcohol withdrawal, they might have tolerance to the medications you're giving them. So they might need larger doses of your replacement therapy. So dual diagnosis, this is when a patient has a substance disorder, and a psychiatric disorder at the same time. Um, and there are programs, including different 12-step groups, Dual Recovery Anonymous, that target both problems. All right, so your assessment, so we'll take a history of their drug use. You might do the CIWA. There's a CAGE questionnaire we'll talk about in a minute. It's just a really brief questions that you can do. It's usually done someplace where you're trying to do a quick screening, like an ER or something like that. And then we have our cows. CAGE questionnaire. Have you ever felt like you should cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt bad or guilty about your drinking? And have you ever had a drink first thing in the morning to study your nerves? And that's what we call an eye opener. And so the last one is really a sign that they have tolerance and they're getting withdrawal very quickly. And so the eye opener is a sign of late stage. But these 4 questions, called the cage. And again, like I said, it's a brief screening device. So our planning, detox, substitution therapy, that's what we, with the depressants like alcohol and benzodiazepines and barbiturates, what they do is they depress the cardiovascular system, and so your body upregulates to keep everything normal while you're depressing yourself with your substance. And then when you suddenly take away the substance, there's nothing holding it down. And it's still upregulated. So that's why the blood pressure skyrockets, the pulse skyrockets, and there's a risk for seizure. So what we do with substitution therapy is just the substitution is you're substituting like a Ativan for their alcohol that they would normally do. It gives the body a chance to adjust to not having the substance. All right. So explain to the patient what's happening. That's always important. When they're in detox, that they're not really in a place they can learn, but once they're toward the end, um, help them get a bigger idea of what's going on. Education is and assistance to the family. There's 12-step groups for the family as well. And we're going to talk about AA in a second. So Alcoholics Anonymous, it's a peer-led, it's people that are alcoholics. There's no professionals in there, at least not in a professional capacity. And it's a organization that's been going strong, and it really helps. A lot of times the person's their whole life, their social system, all their friends, their whole life is based around using their substance. And so for a little while, we need their whole life to be based around not using the substance. So one of the things that 12-step meetings like Alcoholics Anonymous do is they make it where, you have somebody you can always call, which is your sponsor. You have the meetings. There's a lot of them, and they're throughout the day. They're in person and online, and you can almost always find one, you know, reasonably in your area, and if not in your area, you can find them online, and they're free. Number 6, learn how to develop a plan. We're talking about a relapse prevention plan, that has all these ensures safety, comfort, protection, coping skills. See, these are some of our treatment planning options. And while the social worker and the doctor are primarily the ones, if you ever work in case management, you'll be involved in treatment planning, the different discharge options. So motivational interviewing it's a form of therapy where you're consciously trying to help the patient go toward the health changes they want. It was created by William Miller um, years ago to help alcoholics, but it's actually used to help people with different kinds of health behavior change that they need. We have our stages of change model. So these stages, the first one, pre-contemplation, that's somebody that is not even thinking about changing. They're totally in denial. They feel like there's nothing wrong, even though they might have tons of consequences. They might even be in jail. Um, then we have our next stage. It's a person that knows they need to change something, but they're not really ready yet. So they're thinking about it, but they're not really taking any steps to plan. They're not taking any, they're not doing anything to prepare. Then our next stage is preparation, where they're not actually making the change yet, but they're trying to put things in place. They might actually even get AA schedules, get an idea where they're going to go. Um, might have they're looking into where to get detoxed, all of those type of things. And then action is where they actually take the steps. They go to an AA meeting, they go to a hospital to get detoxed. They actually do something. And then maintenance is, after they're stabilized and they're trying to get back to their life. And so a big part of that, and sometimes people, when they present the stages of change model, they'll add on relapse as part of it, because part of our changes, when we make any kind of change in our life, is, things will fall apart, things will get bad, and you'll temporarily go back to those unhealthy behaviors that you were doing. And the idea with that is just to get back to get back into your action again, to get back into your positive changes and get back to maintenance. Okay, this is an example of a relapse prevention plan. So this is, somebody, they have a they realize their trigger is they pass, you know, driving home, they're tired, they pass by their bar, and they don't want to, you know, they don't want to have to go in. And so they know if the outcome that they don't want is to engage in drinking and all these things, that's their list of all the bad things that can happen if they go in. These are their emotions. And then the alternative action, the thing that they want to do, is review their relapse prevention plan, call their AA sponsor, attend an AA meeting, um, do some of their therapy work, or exercise. Exercise is great for people, especially in early recovery, because it releases your own endorphins, and that can relieve some of the feelings that they have that are negative. Okay, objective 7: how to make appropriate community referrals. So what's good, if you are in a case manager type of role, um, then patient's insurance will send you providers. If you're looking to send them to a provider, set them up with an outpatient therapist or psychiatrist, internet resources, and then this government organization here will help find treatment as well. Objective 8: gain an understanding of chemical dependency in the profession of nursing as it applies to impaired nurses. And so, it's estimated that 10 to 15% of nurses suffer from chemical dependency. Alcohol is the most abused drug, but narcotics are not far behind. And so these are symptoms of somebody might be a chemically impaired nurse, just like anybody else in any field. But the thing that's different, as a nurse, we're trusted with these controlled substances. We're trusted that when I take out medications to give to a patient that's in pain, that I'm going to actually give them to the patient that's in pain, and that I'm not going to take them myself to get high. And so that's a big trust that society places in nurses. Um, so anyway, these are some of the things. The one that stands out is the increase in wasting of drugs. That's why you have to have somebody that wastes a controlled substance with you. If there's controlled substances, we have to count them, and then if there's a discrepancy, you have to resolve that in the Pyxis. So if you do get an addiction problem, the Board of Nursing, they can suspend your license or deny or revoke your license, but they try to not do that. They want to do diversion programs to get you to seek treatment. Now, it's not pleasant. A lot of times you'll have to come back, and you have to be supervised by another nurse for the first 6 months or so of your when you return to work, and you'll have to have drug treatment, drug tests, and all of these kind of things that are very unpleasant. You have to pay for their investigation. Um, it can be a lot, and this is, even if you do something that's away from the hospital, like if you have a DUI, you have to go through a big program with that too, and it costs you a lot of money to maintain your license. All right, so the signs and symptoms of codependency and their relationship to substance abuse. So codependency is when there's people in the life of the addict that do things that enable their addiction to continue. They do things that protect the addicted person from the consequences of their actions. Um, and they do things that actually, they're usually well-meaning, but they help the person maintain their addiction. So these are some parts of it. Um, they're trying to control the other person. Their focus is on the other person. There's, these are things hiding the supply. Um, like I said, the big one is protecting the user from the consequences of their use. All right, so our objectives. So define substance use disorder. You saw those 11 criteria in the mild, moderate, and severe. I think that kind of takes care of itself. Demonstrate increased self-awareness. That's something you really need to look at your feelings so that you're not mistreating your patients that come in and need help with addiction. Number 3, the compare and contrast the major categories. So remember, the the depressants are the ones that the patient can die from the detox, and that's alcohol, benzodiazepines, and barbiturates. So those are the most important to make sure you're prioritizing their detox. And then the other ones are just very uncomfortable. Um, the opiate ones that are detoxing, you want to make sure they, especially if they're have a lot of shame, that you're congratulating them and you're like celebrating them coming for help. Fetal alcohol syndrome, again, you want to help the mother that has the child with the birth defects from their drinking when they were pregnant. You want to help the mother let go of some of that guilt. And one of the things when a person with a alcohol or any kind of drug problem, when they feel that intense guilt, what do you think they do to relieve those feelings? They're going to go use their substance again. They're going to escape into their illness. And so we don't want them to do that. We want to try to help them build some self-esteem around, I'm going to make sure this kid has a good life. I'm going to be them, I'm going to be there for them from here on out. Number 5, let's see, identify behaviors and genetic and environmental things that contribute to substance abuse and plan to reduce risk factors. And so that can be, just giving an example of the relapse prevention plan we were looking at a second ago. Some of the ways to avoid your triggers are not driving the same way you drove home every night. So you don't go by that bar that you went to all the time, where you know the bartender and those type of things. Number 6, work with the patient to develop a plan that ensures safety, comfort, protection. And so anyway, this can be very detailed, but what we discussed in the lecture, is having a plan that where the social needs are taken care of, where they're able to find help easily when they need it, like calling a sponsor. And then number 7, the community referrals. And like I said, if you work as a case manager, you'll have all of this, but basically getting the list of providers you can refer to from the insurance. It's nothing worse than getting referred to a provider and then finding out they don't take your insurance. And all the other things that people can do, the 12-step meetings, those that website that from the government that has all the programs. Number 8, gain an understanding of chemical dependency and nursing. You know, nobody ever goes into nursing with the idea that I'm going to divert the meds. Um, but you know, it's an easy thing when you're under stress, and you know, you may have gotten out a benzo medication for the patient, and then you go in and they're asleep, and it's a hassle to return because it's a controlled substance, and so you know, there's a line that you never want to cross where you ever keep it for yourself. You want to always return that. Don't, you know, that once you go over a line like that one time, you know, the next time it'll be much easier. And it might be even that you hold it back from a patient that actually does need it. So number 9, review the signs and symptoms of codependency and discuss the relationship to substance abuse. And so with codependency, it's the person that enables the person to continue their addiction, and you know, doesn't do the things that you need to do to help your loved one get into treatment. All right, so that's it for me. If you have any questions, please let me know.